Okay, we're back. And this basically is what I think we've already talked about in the EDC or the EDB. And there it is, estimated date of birth, determine first day of last menstrual period, subtract 3 months, and add 7 days plus 1 year. Obviously, it's going to be the next year. Most women give birth from 7 days before to 7 days after the estimated date of birth. That's very, very common. Okay, now we're going to talk about some presumptive, probable, and positive signs of pregnancy. This is just theoretical. You're only going to see this in theory class. You're never going to hear this in the hospital. You're just not. Maybe some positive signs, but definitely not the rest of this stuff. But anyway, presumptive, meaning we're presuming somebody might be pregnant if they have a missed menstrual period, but we also know that can be many other different things. A home pregnancy test can be positive. They've gotten much, much better than they used to be, but we can have false positives. Amenorrhea, lack of menses, nausea and vomiting, breast tenderness, urinary frequency, fatigue can all be related to morning sickness. And then quickening is the perception of fetal movement, and sometimes it can be basically psychological, they say. Probable indicators, meaning you're probably pregnant, would be a uterine enlargement and what they call uterine souffle. And uterine souffle can be heard when you're auscultating the abdomen over the uterus. It's like a soft blowing sound like a wind, and it's the same rate as the maternal pulse. And it's due to an increased urine vascularization and the blood pulsating through the placenta. So why this isn't a positive indication is beyond me, but that's what your book says. The uterine souffle can be a probable indicator. Braxton Hicks contractions, we know, can be just false contractions. Uterine changes, meaning Heger's, Goodell's, or Chadwick's sign. And these are all changes that have to do with the uterus that we've talked about prior to. Hager's has to do with the actual bottom of the uterus. When you're palpating, that area is actually softened. Goodell's sign has to do with the softening of the cervix, and again by palpation. And Chadwick's, you don't even have to palpate. Remember, C goes with color, and it's a bluish discolorization of the cervical area because it's so congested with blood, and that's a sign of pregnancy also. Ballottement is passive fetal movement. It's like when you tap the cervix, you can actually feel it feels like a ball that's floating up. And then a positive pregnancy test is going to be in all of them. Let's see. Positive indicators are going to be a presence of a fetal heartbeat distinct from the mother's. So you're hearing two different heartbeats. The mother's is going to be much slower. Obviously, normal fetal heart rate is anywhere 110 to 160. That would be tachycardic for the mom. Fetal movement felt by someone other than the mother. And then visualization, meaning all of this has to be separate from what the mom is saying. And if you look at all of this, most of this, sometimes uterine souffle can be just mistaken for, a murmur in the mom. Braxton Hicks contractions, are they there or not? Uterine changes, I don't know how that can be probable, except that maybe something else is going on and it's not a pregnancy. Same with ballottement, and then the positive pregnancy test. Presumptive, same thing. A lot of this is what's going on with the mother. But in the positive indicators, it's something that we can tell that is distinctly different from the mom. Again, different heartbeat, fetal movement is felt by someone other than the mother, and the visualization through ultrasound examination. Those are positive indicators of pregnancy. Okay, now we're going to move into what is an ultrasound. And this tells everything that it does. Rule out ectopics or molar pregnancy, detection of any maternal abnormalities, problems with the baby, the estimated date, determination and location of the placenta. Is it a normal size? And you can go ahead and read the rest of what's in that one. Amniocentesis, what is that? That's where they go into the uterus with a big, huge needle. It's the biggest needle I think I've ever seen. on the barrel of a very huge syringe, because you have to remember they're going through 4 layers of skin, that very, very thick muscular organ, the uterus, to get into that sac. Can be performed at 14 to 20 weeks. Transabdominal puncture of the amniotic sac. Aspiration of 20 to 30 cc's of amniotic fluid, and you know how much that is. That's why the big barrel syringe. Let's see, you can read the rest. In early pregnancy, a full bladder helps move the uterus into a better position for the procedure. And in later pregnancy, they want that bladder collapsed to minimize the risk of puncture, because again, it's right there. So that's good to know. Amniocentesis, you can examine fetal cells present in the amniotic fluid to determine any chromosomal or biochemical abnormalities. Genetic disorders, the fetal lung maturity, which would be that LS ratio, lecithin to sphygmomyelin. Infection, severity of RH sensitization of the baby, and gender of the fetus. Risk associated with amnio, they're upsetting the apple cart. They are actually in the amniotic sac. So we definitely can have an SAB, which is a spontaneous abortion. Biggest problem because they're interrupting the environment. It says the complication rate is 0.5 to 1%, but boy, I've known a lot of nurses actually that have gone in for amniocentesis to see if there was anything wrong with the baby, or they had the baby very late, so they wanted to see if the baby was normal, and they went into an abortion. We can put infection, obviously, into this because of what it's an outside procedure. The amniotic fluid can leak out. We can have premature ruptured membranes and preterm labor that would go along with the spontaneous abortion. Premature separation of the placenta. All of these. Trauma to the intestines or bladder. Trauma to the fetus, placenta, or umbilical cord. And isoimmunization, meaning if it's an Rh negative woman, she definitely needs to get RhoGAM just in case the baby is positive, and she can make antibodies against that infant if we don't stop that. Then we have AFP screening, and AFP is alpha fetal protein. It's produced by the fetus and found in fetal plasma and escapes into the amniotic fluid. That's why we can get it from that. Low levels of AFP, they'll say, is trisomy 18 or 21, and trisomy 21, of course, is Down syndrome. And high levels of AFP can indicate neural tube defects, abdominal defects, and multiple gestation. False positive rates can be up to 7%. This is the saddest thing I've ever seen. It's optimal time for test, 16 to 18 weeks. In this state, we usually do an AFP test by 20 weeks. And I cannot tell you how many people have thought they had a Downs baby coming because of this test. And I don't agree with the test. I hate it. In fact, most of the people that have told me they thought they were expecting a Downs baby and they almost aborted that baby because of it, but they didn't. And then they have a normal child. So I've also picked up babies with neural tube defects that was, classic, huge spina bifida. If that's not a neural tube defect, they had a normal AFP. So I personally do not trust this test, but this is what it indicates for low levels or high levels. A non-stress test, it really tests for fetal well-being, and that's why I have put that bolded in here. A rationale behind the test is a healthy fetus will produce characteristic heart rate patterns at rest and in response to spontaneous fetal movements. These heart rate patterns indicate an intact central nervous system, meaning if we're going to stress the baby, is the heart rate going to go up? An adequate uteroplacental perfusion, and therefore we have fetal well-being. Reassuring signs is a good baseline fetal heart rate, 120 to 160. Fetal heart rate variability, meaning they are reacting to what we're doing, and accelerations of fetal heart in response to fetal movement. The normal irregularity of the cardiac rhythm would be our NSTs, our non-stress tests. Fetal heart rate variability, again, reflects the continuous interaction between the sympathetic and parasympathetic nervous systems. Intact neurological pathway, obviously it's intact if you have a relationship between the SNS and the PNS. Optimal fetal oxygenation and the measure of fetal reserve. So basically, our fetal heart rate variability is the most important fetal heart rate characteristics. It reflects good oxygenation and perfusion and appropriate neurological modulation of the fetal heart rate, which means they have an intact brain. And of course, we want that, right? And that is the end of our module on the antepartum. Hopefully most of it made sense to you. If not, please bring your questions with you. We will do an estimated date of birth and confinement, a couple of those problems when we all meet. So that's the end of our antepartum prenatal. Again, you can email me questions also. Other than that, I will see you in class. Take care.